Good evening, everyone. Good evening. Thank you for joining. Thank you. Your patience and cooperation is appreciated. Today's webinar on post-renal transplant proteinuria evaluation by a pathologist. Our speaker is very renowned Professor Dr. B.H. Srinivas Sir from Department of Pathology, JIPMER, Puducherry. Sir has almost 178 publications, 51 in renal and transplant pathology. He has done ISN ANIO fellowship and also PDCC at Apollo Hospital, Jubilee Hills. Sir has done observership in liver and transplant pathology at ILBS New Delhi. He is Executive Council member of Indian Society of Renal and Transplant Pathology, an Institute CPC coordinator, and also MD course coordinator. Sir is secretary of JIPMER Scientific Society and has been awarded as Young Scientist for a paper on spectrum of crescentic glomerulonephritis at IAPM 2010 and also by Dr. D.N. Das Best Paper Award 2013 for his original article in IJHBT. So we are eager to hear you, sir. Over to you. Thank you for taking out time. Thank you.
A very good evening to all. Before I start my presentation, my sincere thanks to the ISOT executive team as well as Dr. Radhika for giving me this opportunity. And in the classes, the next class is on evaluation of the post-renal transplant proteinuria, a pathologist perspective. Though this is a pathology presentation, I am trying to balance both clinical as well as a pathology views in this topic. So whenever there is a post-transplant biopsy, these are the common questions usually arising from the practicing nephrologists. So what is the diagnosis? Is there any rejection or any infection? That curiosity usually pathologists will get from the nephrologist. Or is there any associated changes like CNA toxicity? And after once we confirm whether it is rejection or infection and CNA toxicity, the next question from the nephrologist, how active is the lesion? And is there any scarring has occurred? And finally, if nothing is there, they will question last question whether is there any recurrence or de novo disease. So these are all the common questions we pathologists used to face from the nephrologist. So now I jump into my topic scenario. So this it will go into the again introduction, measuring and defining the proteinuria, types of proteinuria like tubular, glomerular, and post-transplant, and causes of the proteinuria in kidney transplantation and biopsy correlation. I will show you the few case scenarios. Consequences of the post-transplant proteinuria. So these are all the pathology and how to again the little bit clinical monitoring and treatment of the post-transplant proteinuria and the future directions and conclusion. So in these headings, I'll go into my presentations. Okay. So proteinuria is often a marker of the allograft damage and is a potential modifiable risk factor, and it is important to recognize early. So it can occur even immediately after post-transplantation. It sometimes immediately, sometimes after a few years also. So the prevalence, if you see into the prevalence of the post-transplant proteinuria after 1 year of the transplantation, the range is between 11 to 45%. If you see the differences, it is a huge variation is there, 11 to 45%. Again, this variation mainly depends on what criteria we use to define the proteinuria. It can be in the native or it can be in the post-transplant. So that is the most important. So to address this, I'll tell briefly about how we are measuring the proteinuria and what type of the proteinuria usually in the kidney and kidney transplant. Sorry, it's not. So usually we can measure the proteinuria three main methods, like either it can be 24 urinary collections, though it is a good method, but sometimes it's not really feasible. The other method is measuring the albuminuria. Third method is the protein creatinine ratio. So using the 24-hour urinary protein collection, there is a greater than 150 milligrams per day is considered as abnormal. But whereas That is for the 24-hour urine protein collection. But the random urine PCR, if greater than 200 milligrams, is considered as pathological. So once we are measuring this much of the proteinuria, we can consider it is a pathological, and we need to evaluate what is the underlying cause for this post-transplant proteinuria. But if we measure only the albuminuria, if it is more than 30 milligrams per day, that should be considered as a abnormal. As we used to know that during our MD course also, during up to 29 milligrams is a normal, but 30 to 300 milligrams it's considered as a microalbuminuria, and more than that it's macroalbuminuria. So this is the second type of the proteinuria. The third type, so usually there are three types of proteinuria, a collection of the post-transplant proteinuria. Either it can be 24-hour collections, albuminuria, or it can be the PCR. So usually the 24 hours urinary protein as well as the PCR both are really good. And if the studies, it says that the correlation between the PCR and 24-hour urinary protein range from the 0.77 to 0.99. So we can use any of these two protein measurements methods. Okay. So these are all the types of that, how to measure the proteinuria and what are the different types of the proteinuria. Again, there are the tubular proteinuria and the glomerular proteinuria. Tubular proteinuria, usually whenever the tubular proteinuria, the quantity of the proteinuria is little bit less. The most important ones is multiple myeloma, and other methods usually in the post-transplant setting, ischemia, reperfusions, acute rejections, use of nephrotoxic drugs, and rarely the congenital tubular defects. These are all the rare, but usually in the tubular proteinuria, the quantity is less. The glomerular proteinuria, usually the mutations are within the podocytes that is causing the podocyte injury, or it can be selective or non-selective proteinuria. Usually selective is albumin, non-selective is non-albuminic proteinurias, like it can be the alpha-1 microglobulin or beta-2 microglobulin, those. The other one is nephrotic or non-nephrotic proteinuria. So these are all, and usually glomerular proteinuria quantity is little bit higher side in compared to the tubular ones. So these are all the main differences between the tubular proteinuria and the glomerular proteinuria. Usually the tubular proteinuria, it's a usually the low molecular weight proteins, but the glomerular proteinuria is more than high molecular weight proteins. And again, the urinary excretion in the tubular proteinuria, as I told before, more than 150 milligrams, but here it is a higher quantity of the proteins. And etiopathogenesis, it mainly the proximal tubular defects like multiple myeloma, congenital tubular defects, or it can be ischemia, reperfusion injury. Or in the glomerular, it's mainly the alter the morphology and function of the actin and cytoskeleton of the podocytes. So that is causing the mainly the glomerular proteinuria. So these are all the basic of the tubular proteinuria, glomerular proteinuria. So coming to our topic scenario, what post-transplant proteinuria. So the post-transplant proteinuria, it can be seen immediately after the transplantation. It can be seen immediately after transplantation, and it can be after the gap. It may be a 1 year or 2 years. More than that also. So the main question is that whether the proteinuria, whichever is coming from the urine, whether is it coming from the native kidney or is from the allograft. So usually the proteinuria, once it's coming from the immediately after the post-transplant proteinuria, it may be the native kidney. Okay, but usually if it is post-transplant proteinuria, it will continue it like that. Usually native proteinuria, it will resolve within a short span of time, within 1 month time. If the proteinuria coming from the native kidney, it will resolve. But if it is really persistence or late appearance of the proteinuria, that indicative of the sign of the graft of the injury. So that we need to remind that the persistence or late appearance of the proteinuria is a sign of the graft of the injury. So what are the main causes of the proteinuria and the post-transplant proteinuria? So again, it can be divided as a tubular proteinuria as well as glomerular proteinuria in the setting of the post-transplant. So though most causes of the proteinuria is tubular, and as I told that it will be the low quantity. So the most important causes are ischemia, reperfusion injury, acute kidney injury, or acute rejections, or mTOR inhibitors, CNA toxicity, or aminoglycosides, or sometimes antiviral drugs. But again, what are the causes of glomerular proteinuria in the setting of the post-transplant? We all know that its most important causes of the glomerular disease, de novo, or it can be recurrent systemic diseases. That other causes are again the transplant glomerulopathy and the chronic rejection. These are all the most important causes. And mTOR inhibitors, CNA toxicity, and these are all the hepatitis C or B. These are all the causes of the glomerular proteinuria in the post-transplant setting. So what are the correlation of the proteinuria in correlation with the biopsy findings? So usually lesions on the renal biopsy, it tends to appear before the clinical manifestations. Okay, so it will be appear before the clinical manifestations. Once the proteinuria is set up, little bit of the amount of the proteinuria, the clinically it may appear, but the biopsy findings are little bit appears little bit earlier ones. So whenever the proteinuria, if it is more than 1500 milligrams per day, it is suggests most of the times, 80% of the times, it's a glomerular pathology. However, a lower level of the proteinuria, if it is below 15 grams of below 1500 milligrams of proteinuria, we are unable to differentiate other pathological diagnosis. So we don't know whether it's a glomerular or tubular proteinuria. So the other important finding is that the urinary levels of the specific proteins could not differentiate between the histological groups. So we need to work it out with the biopsy. So these are all the biopsy findings, but sometimes, rarely, even the biopsy, it may show normal histology, but clinically it will show in the significant proteinuria. So that time the biopsy may not be the answer for the proteinuria. We need to look for the other clinical causes. Okay, that I will discuss in my next presentation. So I'll show you some of the biopsy correlations, what are all our experience in the JIPMER Pondicherry. So this is a case one, 42 years male, underwent living donor kidney transplant. And the basic disease, chronic glomerular disease, and baseline creatinine is 0.9, and systemic hypertension, type 2 diabetes mellitus, post-transplant setting. And the patient is on insulin therapy. And suddenly, after 8 months, there is a graft dysfunction with a proteinuria, 2.8 grams proteinuria and increased serum creatinine. So you can observe there is a significant amount of the proteinuria, 2.8 grams. So the graft biopsy is performed after 8 months of the post-transplant biopsy. Post-transplant. So these are all the pathological features. Biopsy, very good biopsy. It is showing the good number of the glomeruli, but there is no significant glomerular features. Even the tubules, it is showing the ATN. And even the PA sections, it is showing occasional tubules, peritubular capillaries, it is showing the lymphocytic infiltration, but it's really non-significant, below 10%. And we worked up with the C4D as well as even the viral markers, both are negative. So this is a C4D. So it's negative. There is no staining in the PTCs. Even the viral markers SP40 and CMV also negative. So we ruled out rejection as well as a virus. So what it could be the. So once we looked into the biopsy, if you see into the mini tubules, it is showing the fractured cast along with the associated significant ATN changes. So these are all the fractured casts. And even the silver as well as the Mason trichrome, it is showing the fractured casts. Okay. And focal areas, it is showing the fibrosis also around say 20%. Okay, so this is and immunofluorescence. So we thought it could be cause nephropathy. Immunofluorescence, all the heavy chain as well as the C3C1K is negative. But again, the lambda is very strongly positive in these fractured casts and kappa is totally negative. So we rolled out light chain cause nephropathy and worked up with the bone marrow. It is showing around 40% of the plasma cells. Okay, and even the electrophoresis, it is also showing the M band in the gamma region. And even immunofixation also shows M band in the gamma region as well as a very high lambda and kappa ratio. So that is confirmed as a light chain cause nephropathy in the kidney transplant. So that is the case number one. So that is a path of the transplant proteinuria is light chain cause nephropathy. So the second case is that this is a case of the 23 years male. This patient is presented with post-transplant proteinuria around something 24-hour proteinuria is 1.5, and there is a macroscopic hematuria. Transplant biopsy was done, and if you see into the here, it is showing the glomeruli, it is showing the segmental sclerosis as well as mild increase in mesangial cellularity, and again immunofluorescence, it is showing the IgA, C3, kappa, lambda. So this is it is, and even the C4D and the viral markers, everything negative for the rejection as well as infection. So this is a case of the post-transplant proteinuria present in the recurrent IgA disease. So that is the second case. And third case is a 24 years male, bilateral shrunken kidneys, basic disease undetermined, and obesity, suspecting obesity related glomerulopathy, and live related allograft kidney recipients, and the donor is father on triple drug immunosuppression. Day 36, this patient is presented with the worsening of the renal function, urine protein is 1+. And the graft dysfunction, suspecting is rejection or the CNA toxicity. So if you see into this biopsy, but if you see into proteinuria is a little bit less in compared to the previous two cases, 1 plus, and the biopsy if you see into the glomerular normal, but the interstitial mention the very significant interstitial inflammation more than 50%, and there is evidence of the glomerulitis forming the eosinophilic casts. So you can appreciate occasional tubules it is showing the lymphocytic tubulitis on the PA section. And some of the arteries you can appreciate even below the intimal layer lymphocytes as well as some eosinophils also present. Okay, lymphocytes as well as eosinophils which is lifting the underlying the endothelium. So interstitial again this is a C40 which is negative. So if you see this is a case of the, so if you see what are the morphological features, the glomerulitis and endothelitis, significant interstitial inflammation. So this that it fits into cell-mediated rejection because of this significant interstitial inflammation as well as V1 lesions, eosinophilic rich cell-mediated vascular rejection. So here the rejection, cell-mediated rejection, it is causing the proteinuria. So what I mean to say that the level of the proteinuria also the causes might be the different. We can suspect by seeing the clinical presentation biopsy most of the times, but not always. So this is case 4, 51 years male underwent living donor wife kidney transplant recipient. Basic disease chronic glomerulonephritis, systemic hypertension, and type 2 diabetes mellitus. Here the patient presented with graft dysfunction with proteinuria 3.8 grams and increased serum creatinine 4.3 milligrams. Allograft kidney biopsy done after 23 months of the transplantation. Here see the post-transplant proteinuria after nearly 2 years, 3.8 grams proteinuria. So here, if you see into the glomeruli are enlarged, and if you see into the lobular accentuations, many of the tubules, it is many of the glomerular basement membrane, it is showing the basement membrane duplication. You can appreciate here the double layer of the basement membranes, and even the silver layer also you can appreciate the basement membrane duplications. And again, even in the C40, if you see into the again, there are many peritubular capillaries, it is showing the circumferential positive. So that is a case of the transplant glomerulopathy, which is fitting into the both basement membrane duplication as well as the PTC C40 positive, and even the recent for electron microscopy, that is also it is showing the peritubular capillary, it is showing the multi-layering. So this is final diagnosis of this case is transplant glomerulopathy, which is causing the huge proteinuria after 2 years of the post-transplant proteinuria around some 3.8 grams. So the biopsy correlations, proteinuria. So the other thing is that the most of the time this proteinuria is associated with the drugs we are using the immunosuppression, especially the mTOR inhibitors, especially like sirolimus and the everolimus. So what is the mechanism underlying this mTOR inhibitors causing proteinuria? Still really under the discussion, no definitive etiology. But again, the cyclosporin has a well-known antiproteinuric effects in compared to the mTOR inhibitors. So whenever the patient is transferred from the cyclosporin to the sirolimus, the literature is saying that there is increase in intraglomerular pressure with a concomitant reduction in the kidney reserve, or suggesting that proteinuria may be caused at least partially by the glomerular hyperfiltration. So glomerular hyperfiltration here causing the proteinuria. Okay. So the other mechanism for this mTOR inhibitors is that impaired tubular resorption of the albumin, that is also causing the post-transplant proteinuria. Under the immunosuppression with the mTOR inhibitors, so these may be the development of the FSGS. Okay, so that again how it will cause an FSGS, the mainly interfering with the glomerular filtration barrier, that is causing the reduced expression of the nephrin as well as other split diaphragm proteins, that is causing the podocyte integrity. So whenever we are using the mTOR inhibitors, especially we need to monitor the proteinuria into the serially, whether it is causing any graft damage. So this is one of our case. This is a 40 years male living donor kidney transplant recipient. He is on immunosuppression. Presented with facial puffiness and pedal edema, 24 hours proteinuria 3 grams per day. Urine examination 8 to 10 per RBCs, and allograft kidney biopsy was done. And this biopsy, if you enter again the glomeruli, 23223 glomeruli, it is showing the focal segmental glomerular sclerosis NYS subtype. Even immunofluorescence is negative, it is showing the non-specific positive to IgM and C3. And again, C4D and viral markers all are negative. So this is a case of the focal segmental glomerular sclerosis causing the post-transplant proteinuria, mainly secondary to the mTOR inhibitors. So the other mechanisms, other causes for the post-transplant proteinuria, especially the literature, it says that the patients who received the kidney from the donors positive for the hepatitis C virus. So that is also causing the post-transplant proteinuria, and other mechanisms are delayed graft function, especially the body mass index more than 25. That is also causing the post-transplant proteinuria in the multivariate analysis. So we need to look for whenever the hepatitis C virus donors as well as both body mass index more than 25, chances of the post-transplant proteinuria. So what are the again next? So what is the consequence of the post-transplant proteinuria? So it is causing the graft as well as the patient survival, poor graft and patient survival. So if you see how it is causing a poor graft and patient survival, the literature it says that so patient who are having the 0.25 to 1 grams per day proteinuria, the death of this graft hazards ratio for the death is 2.05. But if the proteinuria is more than 1, the more chances of the death. Okay, that's a chance of the more post-transplant proteinuria, the more chances of the mortality as well as a graft failure. So that is so that indicates that poor graft failure as well as a mortality. So again, there is an influence of the proteinuria that it will be again the shows interaction with original disease. So in patients with glomerulonephritis, hypertension, or systemic disease, proteinuria at 1 year systemically increase the risk of the graft failure. So again, how the post-transplant, so again we need to look for again whenever there is post-transplant proteinuria, this is a major sign of the pathological lesions. Okay, so it is causing different pathological lesions. So but how it is causing the pathological lesions? So this post-transplant proteinuria, that abnormal trafficking of the proteinuria, that is causing the nephrotoxic effects per se. So at that time, there is uptake of the proteins from the proximal tubular cells may be affected. So that is causing again the complex reaction with increased production of the angiotensin 2, endothelin, cytokeratin, cytokines, chemotacrin, and transcription factors. That is causing the promote the lymphocytes and monocyte recruitment with the transdifferentiation of the epithelial cells into the fibroblasts. So that is causing the different interstitial inflammation, lymphocytes, eosinophils, as well as the scarring. So this is the proposed theory how the transplant proteinuria it is causing the effects on the biopsy findings. So the other meta-analysis of the cohort studies, they are showing that there is strong continuous association between the proteinuria and subsequent risk of the coronary heart disease, and especially the microalbuminuria now considered as a marker of the systemic endothelial dysfunction can eventually result in the coronary heart disease or accelerated atherosclerosis. And again, microalbuminuria and mild increase in C-reactive protein in the transplanted patients may indicate an underlying systemic endothelial damage that is contributing the reduced graft and patient survival. So both microalbuminuria and increase in C-reactive protein that is causing the reduced graft and patient survival. So, but how to monitor and treatment of the post-transplant proteinuria? Brief about the clinical aspect. Okay. So we need to regularly monitor the amount of the proteinuria at all follow-up visits by either it can be urine dipstick or it can be but urine dipstick is very highly specific and less sensitive, or it can be 24 urinary protein, which is a really very gold standard, but the collection is a little bit difficult. 24 hour, that is only the main, though it's a gold standard, collecting the 24 hour urine is really sometimes it may be difficult because of low quantity. As well as either it can be urine protein or creatinine ratio assessed as spot urine. So these are all the main, with these methods, we need to monitor in follow-up visits in all graft patients. So again, sometimes non-renal factors, especially the dietary intake of the proteins, physical effort, stress, fever, and acute rejections. These are also acute infections. These are also it can cause in the proteinuria. So before we need to rule it out these causes, especially the dietary intake, what type of the diet they are taking, physical effect, stress, fevers. So whenever the proteinuria exceeds more than 0.5 to 1 gram, that we need to check for any possible false positives. So proteinuria is not confirmed. So it's not confirmed means there is no significant proteinuria. Look for any physical causes like any exercises, high protein intake, fever, infections, and stress. These may be the causing the non-significant proteinuria. But whenever there is significant proteinuria, if it is below 0.5 grams, so you need to monitor daily. If it is stable, no need of the biopsy. But if it is unstable, like if it is more amount of the proteinuria, more than 0.5 grams, more than 0.5 to 1 gram per 24 hours, renal biopsy may be considered for a definitive etiology of the proteinuria. So again, therapeutic approach, the most important step is avoid the glomerular hypertension. So the other therapeutic important things are RAS inhibitors, like which is causing minimizing the microalbuminuria, or angiotensin converting enzyme inhibitors, antiproteinuria effects, or angiotensin receptor blockers. These are all the most important drugs, or it can be any combination therapy can be useful. So these are all the main targeted, main treatment for the post-transplant proteinuria. So apart from these treatment, that other ancillary measures like diet with moderate protein intake and with low sodium content that need to be monitored, and the calorie intake should be just sufficient to maintain the ideal body weight, because especially the obese patients, there are high chances of getting the proteinuria. And avoid smoking. Again, that is also causing the increased urinary albumin excretion. And again, the statins, some patients may be on the statins, which is causing reducing the proteinuria. And the vitamin D, that is also a negative regulator of the RAS to reduce the proteinuria. So these are all apart from the routine therapeutic effects, these are all the ancillary measures really useful to monitor the post-transplant proteinuria, and really equally beneficial in apart from the treatment. So these are also most important. So what are the future directions? Really, the better understanding of the factors and mechanisms to say what are the etiological factors for the post-transplant proteinuria, and detailed prospective cohort study. So really, there are very less studies to know what is exactly the cause of the post-transplant that really important prospective cohort studies. And again, the patients need to be followed very serially to monitor the proteinuria, and the biopsy material as well as the possible markers of the outcomes like DSA would be really helpful. And the different phenotypes at risk of the allograft failures could be characterized to future interventional studies, because different types of the patients may be having the different interventions. So that is also more important. So to conclude, the post-transplant proteinuria is a frequent complication and the independent risk factor of the patient as well as the graft survival. Both. It's both patient and graft survival. So even mild proteinuria may have the prognostic significance. So it's not that more than 2 grams, 3 grams, even a mild proteinuria, 0.5 also have a really significant prognostic significance. Okay, it may be the rejection also. So ideal cutoff for the pathological significant proteinuria in the transplant population remains undefined, because really till now what should be made to recognize the etiology and the kidney wherever required with the biopsy correlations, and impact on the long-term outcome of the existing therapies are really still uncertain, because some of these RAS inhibitors really it may cause in some different type of the cancers in the long-term uses. So that is also need to be defined, because to avoid the other complication of this treatment. So the finally hopes on the drugs that can interfere with the remodeling of the actin cytoskeleton restoration of the glomerular barrier, that is also most important. So these are all the final conclusions for the few definitive etiopathogens of the post-transplant proteinuria as well as the therapy, and finally the better graft survival, that is the most important for all these future settings. So thank you for my this patient listening, and I am ready to answer any type of the questions. Thanks once again ISOT executive team for this opportunity.
Thank you, sir. Thank you very much. Thank you for this wonderful class with detailed explanation, with basics and interesting cases. So there were a few questions, but you already answered. If you want to share those questions.
Yeah, So there are good evening. There are some questions in the chat box. Dr. Pallavi Prasad, she is asking that regarding the recurrent FSGS presenting with proteinuria immediately post transplantation, since the patient is on steroid and CNI in post transplant period, is it possible that EM can show focal food process effacement, or is it always diffuse? Usually in the FSGS, it's the focal food process effacement. But apart from that, you need to look for whether is it recurrent FSGS or is it secondary to CNI. You need to look for other changes of the CNI also, like any arterial ILOCs, calcifications, vacuolations, and those things. But usually in the recurrent FSGS, usually it shows focal food process effacement. That is a question number one. And second question is that somebody, Dr. Rakesh, he is asking, can the proteins be supplemented in proteinuric patients? So that's what I included in my presentation. So yes, these apart from the routine treatment, there will be ancillary measures. That is the most important apart from the routine treatment, like diet with moderate protein intake and a low sodium content. So that should be the need to be content. And at the same time, you need to look for the ideal body weight also, because especially the obesity patients will have the more chances of the proteinuria. So that is one of any other questions, Dr. Radhika?
Yes, sir. There is one more question, but any data on SGL2 inhibitors in this scenario? So,
Any data on?
This SGL2 inhibitors. So maybe clinicians can answer better that.
No, I don't.
Yeah. So one more question. Do we need to send EM routinely for every nephrotic proteinuria patient in post-transplant?
Yeah, that's a good question. Actually, EM is a better because we can't. It will for definitive answer and for definitive diagnosis, especially in the post-transplant proteinuria, we need to send the EM. So routine rejection, if you're suspecting the rejection, it may not be needed. But if you are really proteinuria, you need to suspect the better to send a electron microscopy, tissue electron microscopy, especially to look for the transplant glomerulopathy, for any other causes, any FSGS, what type of FSGS. This really it's needed. Anyway, the other recurrent glomerular disease that we can find it out even with LM as well as IF, but EM is definitely needed for whenever you are suspecting the proteinuria. That's good. Anything else?
So I think that's all, sir. Yeah. So thank you everyone for being there, and thank you, Srinivas sir. So you took out time and gave this wonderful class and opportunity for us to listen to you. Thank you, everyone. Thank you, sir.
Thank you. Thank
Thank you.
you, madam.
Yes.